My name is Maria Weiner, and I'm the president of Florida Caregivers Network. So I am so ready to start this day. I've been ready for the past 7 months.
So have we.
Yes, ma'am. Good morning, everyone, and welcome to the second annual Caregiver Conference, Getting Real About Reality. Today will be a special day for all the caregivers in this room and professionals that care or know someone that lives with dementia. I hope that by the end of this day, you guys are re-energized with all this information we're going to give you, have the tools, have all the resources for you to take care of your loved one. So we're going to start and we're going to get real about reality.
Our next speaker is Mr. James Rooney. He's an advanced registered nurse practitioner, and he will discuss developments in the use of pharmaceuticals and behavioral changes. Mr. Rooney has been a nurse practitioner since 1998. He graduated from the University of Tampa with a degree as a family nurse practitioner, and in 2008 graduated as a psychiatric nurse practitioner from the University of Missouri. He has spent his entire career in the long-term care setting in the Tampa Bay area at skilled nursing and advanced living facilities. Mr. Rooney currently works full-time with Long-Term Care Associates, LLC, a group which manages psychiatric medications. He has experience teaching at the University of Tampa in the BSN-RN program. He has previously published articles on dementia and swallowing difficulties. He is former newsletter editor for local and statewide nurse practitioner groups, serves in the role as guardian to a family member with a disability, and he currently manages residents in Pinellas County. Jim continues his lifelong focus on helping the memory impaired and those residents with serious mental illness. Mr. James Rooney.
Okay, thank you for the introduction there. And I just got some pretty good news on the text. I'm a grandfather for the second time. She was just born 5 minutes ago. And Gracie. So she's healthy and we're happy. Anyway, so my name is Jim Rooney, and like the intro I said, I focus mostly in the long-term care setting, specifically with nursing homes and ALFs. So I see a lot of residents that are already kind of advanced in their memory impairment, and of course they've already gone through a lot of difficulties living at home in the community, and then they require increased help with activities, daily living, those kinds of things. So they do end up needing medication management and care like that. So when they reach that stage, that's when I come in, and I go to the facilities and review them and talk to the staff and look over behaviors and try to help out with medication strictly. I don't do counseling per se, because we do have, licensed clinical social workers and counselors that take care of all that. Now, what I did want to let you all know that I did create a logarithm that we have up here for a handout for you to take home with you. And it's a little short thing here, and it kind of gives a short synopsis of some of the medications and types of reasons why we start medications, in what order, and generally the practice that long-term care does, and trying to help out family members and with residents with behavioral problems. And I'm sure throughout the day you've talked an awful lot about all kinds of behaviors that you have to put up with when your loved one is having memory problems, and like I said, when I see them, they tend to be a lot further along. So I'm dealing with somebody's in states of disorientation. They might be wandering throughout the facility, trying to elope from the facility, not knowing where they're going. There could be other issues going on in moderate and advanced dementia, yelling, screaming, fearfulness. They may be reliving some past bad episodes that may have happened 30 or 40 years ago, fires, things like that. So there's a lot of different behavioral symptoms that I try to help with. So even though I look over somebody and I put a diagnosis of depression or anxiety, or they may have, of course, dementia, and they may also have long-standing psychiatric illnesses. They may have a long-standing diagnosis of bipolar disorder or schizoaffect disorder, and they may have been on, medications for long term. I kind of just focus on, what kinds of behaviors are they having, and what can we do to improve them? Because improving the behaviors often helps with that person's quality of life. Okay, because nobody can be in a happy state of mind if they're screaming, confused, yelling, having other issues, incontinence, having inappropriate behavior, agitation, aggression. And there can also be a lot of delusions that can occur too in advanced states of memory impairment. So I kind of look at the whole picture of those things and try to help out. And when I do see one of your loved ones in a advanced living facility or a nursing home, one of the first things I do is kind of review to see what kind of medications have they been on previously. And I try to talk to the loved ones, family members if I can, get a picture of how they were behaving in the past, how many years has this been going on, and months have been going on, and the axiom of going with slow amounts of medications, small amounts, and going very slowly, very important. Side effects are a critical problem in the elderly. There is lots more side effects. Your body can't necessarily metabolize the medication as well. You may have been on a particular medication for many years, and then your body's changing, and it's having higher side effects. So, oftentimes I'll have the wife let me know that, he's been on this same milligrams for 20 years, not a problem. Why do you say now we have to reduce it? Well, because the body has changed. So you have to recognize that when we get into our late 60s, early 70s, depending on the individual, could be the 80s, you have a lot more difficulty metabolizing medications, and so they have different adverse effects. So some of those things have to be taken into account if you have a long-standing mental health issue and you've been on medications in the past. Now, what I look at primarily when I come in and see somebody in a facility is, those kinds of behaviors. Are they having, sadness, worrying, frustration, and irritability? And those kinds of things, milder symptoms, I kind of target more toward an antidepressant, thinking in terms of trying to help out for, what is causing, what is the medication adjustments needed. There's different categories of medications for depressions, and the most common one is the SSRI category. And in that logarithm that y'all can get on the way out there, you can put it in your purse and your wallet and that if you need to refer to it and kind of look it over. If you find yourself in a situation where your loved one's in a nursing facility and you're frustrated over maybe too much medication or not enough, what kind of input can you give to the staff or to the primary care doctor or a psychiatric nurse practitioner or psychiatrist to kind of say, hey, we need some help here? And generally what I do when I look over somebody is think in terms of what order and level of medicating do we want to do. And the lowest medication is best. Antidepressants generally tend to be the first category. Then I kind of look at the issue of memory protection. Sometimes memory protection medications as a second category. Is if behaviors are worsening, mood stabilizers may need to come into play. And then the final most side effect category would be the antipsychotics. So in that order, looking at the level of behavioral issues, we may tend to hopefully only use one category on somebody and make a great difference. So if I come in and see somebody who, for example, maybe 85 years old and suddenly they're just really irritable, refusing to take medications, angry all the time, I kind of think in terms of, is this person suffering from some anxiety issues? They're depressed, they're sad, or they're having periods of frustration, which is reflecting with excessive irritability. So in those cases, a lot of times I will start somebody on an antidepressant, over a period of like 2 to 4 weeks to see if that brings down that level of depression and as well anxiety. Because the category of the SSRI and some of the antidepressants, they don't just help with depression, they also have a secondary role in reducing anxiety and worrying and that type of thing. And so that it's kind of a misnomer when you just see, hey, I'm putting your dad on an antidepressant. Well, he's not depressed. Well, maybe we're putting him on it for the effect of reducing his anxiety and frustration. Maybe he was a busy, physically active guy, and now he can't move around much, and he's totally frustrated, lying in bed and not being able to have any independence for whatever it may be. A stroke may have happened, or a heart attack, things like that limited his independence. So that's going to trigger the frustration on that type of individual, and an antidepressant may be just all we really need to add to his regimen to kind of bring him up into a better frame of mind and to be more cooperative and have a better quality of life for himself. Now, some of the antidepressants that we do give also is there's a second category known as the SNRI, the serotonin norepinephrine reuptake inhibitors. Now, those medications include Effexor, Cymbalta, Pristiq, and those are kind of like a combination of the SSRI medications and other types. And in the SSRI category, by the way, those medications you probably are very familiar with: the Lexapro, Celexa, Paxil, Prozac, Zoloft. All of those kinds of medications are in the same category. They tend to have more of a calming effect on people, on individuals, and kind of chilling effect, and maybe less irritability, less frustration, less anxiety. The third category is aptly named other antidepressants because it doesn't fit into the other categories. So, and in that one, there's kind of a pharmacologically mixed types of antidepressants. The most common, well-known one is Wellbutrin. That's a medication that tends to not necessarily reduce anxiety, sometimes the opposite effect. It'll tend to boost things up a bit. So in some instances, some people need that. They need more energy. They may be lying in bed and kind of giving up on life and don't want to try and don't go to therapy and don't want to talk maybe. In those instances, maybe a Wellbutrin would be more helpful because you want to boost their energy and boost their interaction. And they're not necessarily having any kind of anxiety. They're just kind of giving up on life in a sense. So that's helpful. And within that category of other, there's Remeron, Trazodone, Doxepin, and Vibrid. And they have varying helpfulness on different types of behavioral issues. Remeron is very successfully used in low doses to help boost a individual's appetite, so that if you're having difficulties swallowing with the dementia process or losing the desire to eat, the taste buds aren't there, you're depressed, you don't want to eat, or you're choking a lot and just kind of don't want to eat out of fear of choking, then to gently help boost the appetite, sometimes we use an antidepressant with the secondary effect of depression with poor appetite might be a diagnosis for that. But they are officially antidepressants. The other types of antidepressants we use routinely is when people are having sleep problems. As we know, sleeping is very, very important to me, and and to everybody, right? If you don't sleep, you're grouchy, you're irritable, people get into car crashes, right? You just don't have the sharpness that you should have. And even during the simplest of things like daylight savings times, when we lose an hour of sleep, it's been shown nationally to increase significantly the incidence of car accidents on the general population. So it affects us all, and it affects us tremendously. So sleep is a very, very important behavioral analysis to make on somebody in a setting, whether it's ALF or a skilled nursing facility. You want to know, is this person falling asleep easily? Once they do fall asleep, do they stay asleep, or are they getting up 2 hours later and staying up for 3-4 hours and then falling asleep again and being a state of irritability come morning time? And so in those instances there are, of course, the medications, Ambien and Restoril, that are controlled substances with higher side effects, and to try to avoid those. So in cases like that, oftentimes the antidepressant will come into play. The trazodone, doxepin, they have essentially the adverse effect of somnolence and causing you to fall asleep. So it's a lot safer without having, hopefully, a hangover effect afterwards. And we try to avoid any kinds of the adverse effect of it lasting throughout the following day, because that, again, what's the good of having a good night's sleep, and then the next day you're drowsy and you fall and break your hip, or get hospitalized and get lacerations and have to go to the emergency room. So it's all about the balance. So as we get older, some of these controlled substances have a much higher adverse effect on us. So try to limit. So that's another example. Just like go slow. Yeah, we do know we have those big guns, so to speak, those controlled substances to make you sleep. But hey, let's try an antidepressant. That's just a side effect that's going to be a lot safer. So that's what I kind of talk to the family members about and helping throughout. So the antidepressant categories are not just for depression. They're for that whole myriad of issues there that we need to help with. And then looking at some other issues of memory impairment, we always see if somebody, how alert and oriented are they? Do they know what month and year it is? What city you're in? Are you alert and oriented times 3? Those are kind of basic things. How about things such as your short-term memory, asking 3-word recall and asking to remember 3 words, and 2 or 3 minutes later say, hey, what are those 3 words I asked you? Or can they do basic math? Can they do spelling? The sneaky mini mental state exam is to have somebody try to spell a word backwards, because that requires concentration, right? So to try to figure out how bad are they on the continuum of memory impairment or dementia. And in cases where they're having mild to moderate dementia, we do kind of analyze and look into see if there's memory protective medications will be helpful. And those ones are well known from the television commercials, your Aricept and the Exelon, and then the other one is Razidine, which is all in the same category. Now what they do is they focus on specific neurotransmitters that's already in our brains, and they try to help boost them to protect the decline in memory. So some of the studies have strongly shown that that category of medicine does delay the further progression of memory impairment, so that maybe if you have the best case scenario, taking these medications, they're not necessarily going to boost your memory at the moment, but in 2 years from now, your memory will not have declined, or maybe 3 years if you're lucky, in some cases a little bit further, and upwards of 4 or 5 years if you're very lucky. And although that doesn't sound like, wow, that's not huge, but it really is. If you're 85 years old and you start taking them, and now you're 90 and you have the same memory, that's pretty good, because our body systems tend, obviously, are going to be giving out with our organs if we're having some medical issues as well. So the goal is to maintain that high quality of life as best as we can, as long as we can. And then, as long as there's no bad side effects to those types of neurotransmitter medications, and they're referred to as a cholinesterase inhibitor category, the Aricept, Exelon, and Razidine. And of course, the number one side effect for those medications is upset intestine, diarrhea. Pretty much all the manufacturers recommend to start it at an extremely low dose, and then after 30 days to increase it and try to get up to the maximum dose within 30 to 60 days, depending on the medication. And then at that point, it's done in that manner to avoid any diarrhea or intestinal issues, and because you don't want to take medications if those things are going on. And fortunately now, too, they're also available in patches, so you can get some of them with a patch. And it seems to, although they also titrate up with a lower dose at first, I think they tend to have lesser side effects intestinally, from my experience. So I'm a fan of the patches, but not of the price of the patches, because everything, being what it is, it's the expense issues come into play as well. And then the other category of the memory protective medication is the NMDA, which is really hard to pronounce. N-methyl aspartate receptor. It's Namenda. That's all you need to know. So that covers a different category of a neurotransmitter. That one came on the market in Europe originally, and then came to the United States. So it hasn't been in the U.S. routinely as long as the Aricept and others in that category. It can be helpful. You kind of have to evaluate. Some people will have improvement with that one. The studies tend to lean more toward the other category. In some instances, the loved ones want to, do everything they can, so they want to have them on both of these medications. So some people are on that to try to, let's keep somebody strong and as good a memory as long as possible. So those are the second category, and again, you'll see those on that little logarithm I left out there, which I think might be helpful for if you find yourself in need of trying to get your loved one in a facility. Now, the third category that we talk about is mood stabilizers, and some of the reasons why would we want a mood stabilizer for mood swings, of course, that's where what we call obviously bad type behavior of screaming and yelling, agitation, throwing things, maybe some hitting going on with in the facilities that I'm in. Somebody with an advanced memory impairment, they may be punching at the staff when they're trying to get them dressed. They don't know what they're, they don't know. They've never been that way their whole life. They're not, mean or anything or changed in that fashion. It's just that the memory losses have triggered more difficult behaviors. So in that category of medication to try to control those behaviors to increase their quality of life, we generally use like the anti-seizure medications, but we're not doing them obviously at the level that you would need to prevent seizures. Those include Depakote, Lamictal, Tegretol, Topamax, and Trileptal. And of course there are other medications in that category as well. But those are the most common ones used for behavioral help if there's some severe agitation going on. And in the other category of mood stabilizers is the lithium, which is, I believe that's our oldest behavioral medication in the 20th century. I think that went back into the 1940s when it was discovered as a help for behavior. And that's basically essentially lithium salt, brought from the earth, and it helps tremendously with preventing severe agitation, and as well as bipolar disorder. Of course, many younger people would take that for bipolar disorder. And that one requires very close blood monitoring, oftentimes monthly lab levels, because it can become toxic, and it takes quite a bit to get out of your body if it does reach a toxic level. And it may take a week to slowly remove. If it's severe, it can be corrected in an emergency room setting, but generally by just holding the medication, toxicity can be brought under control with that. And then the final category of medications that we use for extremely difficult behavior is the category of antipsychotics. It's not the most popular category. There's been some studies that refer to as black box warnings for cardiovascular events on some of them, most of the antipsychotics. And they have to be given very, very slowly, very methodically, to avoid any kinds of side effects. And some of the behaviors we're really concerned with there is the extremely severe that you may see in somebody with the schizophrenia, with delusional thinking, talking to somebody who's not there, seeing things or hearing things, paranoid thinking, thinking that your roommate is stealing all your items when they aren't. Or, for example, the other day, yesterday, there was a resident who wanted the police called because the nurse had stole her wheelchair the night before. However, the nurse had taken the wheelchair because they had to clean it down, and they had switched her to a regular chair, but she doesn't know any better. She just thinks it's been stolen and wants the police called. So, that's a kind of accusing somebody of something they didn't do. They're being a helper cleaning their chair. They're not trying to steal it. And the cursing behavior, and of course combativeness, which is just hitting out at somebody, striking. And the combativeness has different seriousness with each person. Of course, combativeness with someone my build and my strength is very serious, but somebody who's frail and moves very slow and maybe 90 or 100 years old, their combativeness is not that as dangerous, right? So you kind of have to take into account the capacity of the individual to do harm, because sometimes there'll be requests for psychiatric admissions for combative behavior, and so a lot of times I'll take that into account. Those categories of medications we generally use are Abilify, Clozaril, Geodon and Vega, Latuda, Risperdal, Seroquel, and Zyprexa. And there's an older generation as well that you'll see on that handout there that are very rarely given unless somebody has a long-standing serious mental illness such as schizophrenia, paranoid type, or severe bipolar or psychosis, or brain injuries and those kinds of things. So that particular antipsychotic, I always talk to the family members about why do we want to initiate something like that has a black box warning. And I kind of tend to point out, well, did you know that Motrin has a black box warning? That has the same one, that increases cardiovascular events. And there's other medications. Black box warnings mean, be aware that this could be a potential event. So always keep that in mind. Sometimes an EKG is done to double check, and I do those quite a bit to see if there's any arrhythmias or any type of extended QT prolongation that may increase heart attacks and things like that. So anyway, yeah, take the logarithm when you get out there. Sorry I didn't deliver it earlier. I customized and cut them up real good. I used something called scissors, so saved a lot of copying costs. And thank you for your time.